Good afternoon, ladies and gentlemen. Welcome to the CHSRF On Call. I would like to remind you that this conference is being recorded. At this time, all participants are in a listen-only mode. For operator assistance during the call, please press *0. I would now like to turn the meeting over to Dr. Jillian Mulvale, Director of Healthcare Financing and Transformation. Please go ahead, Dr. Mulvale.
Hello, and welcome to CHSRF On Call, an interactive series by the Canadian Health Services Research Foundation. CHSRF On Call brings together policymakers, healthcare executives, researchers, the public, and you to be a part of a dialogue about ways to improve healthcare for Canadians. We are also pleased to now offer new and improved connectivity options for our entire audience, including new web streaming with integrated audio and video, allowing participants to listen through their computer speakers. We are also pleased to now offer simultaneous translation for our French audience. If at any time during our session you experience technical difficulties, please choose one of the tech support options at the bottom of your screen. As indicated, I'm Jillian Mulvale, and I'm the Director of Healthcare Financing and Transformation at CHSRF. I'm very happy to be standing in today for Vice President of Programs, Stephen Samus. So I welcome you to today's call where we're exploring activity-based funding. Healthcare sustainability is a major concern for Canadians. Healthcare costs are rising at a rate faster than revenue growth in most jurisdictions across Canada and around the world. Traditionally, most hospitals are funded through global budgets. However, increasing numbers of provinces and territories are considering or moving to activity-based funding models or blended models for some services in hospital or continuing care. We are very pleased that joining us today to talk about how the way we fund hospitals and post-acute facilities can influence the overall efficiency of healthcare delivery in Canada are Jason Sutherland, Assistant Professor in the School of Population and Health Research at the Centre for Health Services and Policy Research at UBC, and Ian Rongvie, Executive Director, Modelling and Analysis Branch, Planning and Innovation Division, BC Ministry of Health Services. We are also pleased to have more than 200 organizations registered today with representation from coast to coast. Today's call begins with brief presentations from each of our speakers, and then we will open the lines for a question and answer period when we will take questions from you, our audience. Instructions for asking questions will be provided at that time. And now it's my pleasure to hand the floor over to Jason.
Hello, everyone. I'm excited to be here and share with you my experiences discussing activity-based funding, or that is, using analytic methods to provide a firm basis for funding hospital-based care in Canada. Many countries have taken to activity-based funding for different reasons. In some countries, they are using the objective of transforming their funding system to improve the efficiency and the cost efficiency of the hospital care provided. They would like to reduce costs, while in other settings, they would like to improve the access. Often, using activity-based funding methods increases the volume of hospital-based care and thus provides improved access to those on wait lists. In other settings, activity-based funding is used as a basis to drive quality initiatives, such as improving equity of access and timeliness of access and geographic access. What are some of the problems that are driving the funding reform efforts in some of the provinces? In some instances, it can be categorized as overuse of a scarce resource where the marginal benefits to patients is slight. In other cases, it's underuse of a scarce resource whereby patients need access to hospital-based care. In other settings, hospitals are perceived to be effectively running inefficiently compared to their peers and are using economic levers to try to improve efficiencies. In other countries, healthcare spending and hospital spending is viewed as a very expensive item which they would like to improve the transparency with and to effectively use cost control mechanisms. In other health reform efforts, it is an initiative to improve patient-centeredness, as often activity-based funding is viewed as a way of funding based on the patient preferences of where they would like to access care. In other settings, hospitals would like to be funded on different aspects of cost, either on the average cost or for the fixed cost of the hospital, or in marginal costs. Now, hospitals are currently representing over $55 billion in expenditures per year in Canada. In most settings in most provinces, hospitals are funded with a global budget. That is, that there is a fixed amount, a fixed lump sum to provide all hospital-based care for all patients for a given period of time. There are several limitations of a global budget, and I've listed some of them on the slide in front of you. That is, that the methods for determining the global budget is often viewed as intransparent or opaque, such that there's no rhyme or reason with which the amounts are set or change over years. It can be viewed as perpetuating inefficiencies in types of care that are inefficient. There are no incentives to improve the wait times or the access, because in other words, if you improve the efficiency and you have higher volume of care, your global budget does not change. So there are disincentives to improving access in some situations. In other settings, you have unexplained variation in utilization and cost, not quantifiable by differences in patient populations. Hospitals are not rewarded for being innovative and changing care practices to save money or to be innovative with regards to the way that they organize and deliver health services, nor is there an incentives to improve quality of clinical care as well, too. Investments to improve quality are viewed as expenditures rather than being met with improved income or increased income. Activity-based funding is predominantly being presented in some countries as a way to stimulate productivity and efficiency. That is, hospitals will be trying to improve the volume or increase the volume of hospital-based care to capture more revenue. In many settings in some countries, this has been associated with reduced length of stays and reduced access to hospital care, commensurate with reduced wait times. In other settings, such as the UK, activity-based funding is being viewed as a way to increase competitions between hospitals to improve quality. In other settings, it is about facilitating patient choice in terms of where patients access hospital-based care. In other settings, further, such as Ireland, it is viewed as a method for harmonizing payment mechanisms between public and private providers. Now, that's certainly not the situation in Canada, where all hospital-based care is publicly funded. But there are various means and motivations for affecting changes in the way hospitals are funded. Now, on my current slide, I am now discussing some of the pluses and minuses of activity-based funding or funding on volume. Hospitals have the incentive to increase the volume of hospital-based care to improve or increase their revenue, but they also have an incentive to improve the efficiency with which they deliver that care, because they have the ability to retain those surpluses, which they can redirect to other types of patients. There's also political incentives to fund hospitals based on activity, because it removes the argument of how hospitals are funded and inequities or cultural or historic inequities between hospitals. However, replacing global budgets with activity-based funding also introduces a number of well-known challenges. Activity-based funding has been used in many countries for 20 or 30 years and is the predominant method for funding healthcare, hospital-based healthcare across Europe. So it does reward volume, nor are there incentives to improve the coordination of care between settings, such as when patients are discharged from hospital. There are also incentives, and we've seen this in a number of countries, for them to provide more of the profitable services, less so than what is needed by the patient populations. Moreover, there are opportunities for hospitals to provide upcoding, such as that they overrepresent the acuity or severity of their patients, and it's a data-based exercise to improve their revenues. Now, activity-based funding has been used for over several decades, as I mentioned before. There is a good amount of empirical evidence with regards to some of its effects, and I've listed those on the left-hand side of your slide there. It does tend to shorten length of stays. It tends to increase the volume of hospitalizations in most countries. It tends to be associated with increased hospital spending, because increased volume is associated with increased spending. But there's little effect on hospital-based quality of patients, such that it doesn't appear that patients' shorter length of stays are associated with poor clinical outcomes. However, there are certainly noticeable gaps in the evidence. There's no evidence that improves the quality of evidence-based care. It doesn't link to the provision or over-provision or under-provision of the effective or appropriate care, nor is there little research with regard to the impact of activity-based funding in other sectors of care. But these are certainly all effects of global budgets that we have now, too. Now, in practical applications, most settings, most like our own, such as the Nordic countries like Sweden, Finland, and Denmark, use a blend of global budgeting and activity-based funding. So certainly no one is suggesting that the best way to move towards activity-based funding is do away with global budgets. In most situations, global budgets are used to cover at least the fixed costs of hospitals, and activity-based funding is used in an economic lever to try to improve the efficiency and volume of hospital-based care. Countries have varied with the proportional allocation used in activity-based funding and global budgeting, such as the 60-40 split or 70-30 split in some of the Nordic countries. Some of the primarily articulated concerns that stakeholders have are certainly legitimate, and there's in some instances very little evidence to substantiate them. For example, there are human resource concerns that the average acuity of patients treated in hospitals commensurate with shorter length of stays will be increased. The waiting times will go down. The quality of care in many instances remains unmeasured. The access in some situations has improved remarkably with shorter length of stays. Patient satisfaction and the links to activity-based funding is largely unmeasured. However, there are also a number of concerns associated with the outcomes on hospital financial measures, such that inefficient or ineffective-based hospital care is often associated with financial strain on those hospitals, and not necessarily wanting those hospitals to be under financial strain or to go out of business. Now, can activity-based funding be credibly executed in Canada? The hospital-based care and the clinical discharge summary is certainly comprehensively covered in Canadian healthcare. The discharge abstract databases are routinely submitted in a timely manner to the Canadian Institute for Health Information. On the other hand, the financial statistics certainly lag behind to know what the patient-level costs are, such that hospitals are able to actively determine where they are losing and where they are gaining on what types of patients and where potential inefficiencies or efficiencies may be found and how to replicate those in other clinical departments. So I'd like to wrap it up there and hand it over to my co-presenter.
Okay, thanks, Jason. My name's Ian Rongvi. I'm working in the Ministry of Health. I've been working with the Patient-Focused Funding Initiative in British Columbia for about a little bit over 2 years, so a little bit predating the actual establishment of the Patient-Focused Funding Initiative. Now, you will notice that I'm using the term patient-focused funding, and I will correct myself in just a moment, but what I'd like to start with is a recognition that patient-focused funding, the way we've established it in British Columbia, is an umbrella term that covers a number of patient-based funding mechanisms that are all under the same, under the control of the same area. We have an activity-based funding program that I'm going to talk about today. We have something else called the Procedural Care Program, which is slightly different, but is basically contracted volumes for contracted procedures in specific hospitals. We've got an emergency department pay-for-performance system, and then we have just established patient-focused funding in community care, trying to, in essence, facilitate the transfer or the movement of patients from hospital to the community. Our patient-focused funding initiative is established and is under the administrative control of what we call the Health Services Purchasing Organization. It is an independent entity, so it's not part of the Ministry of Health. It is accountable to the Minister of Health for the administration of patient-focused funding. In practice, patient-focused funding really is a cooperative venture between Health Services Purchasing Organization and the Ministry of Health. We have had we have established, or we've had this program underway for about 18 months now. We established it April 1st, 2010. We fund the program. A substantial portion of the funding comes from the global budget for the health authorities. And then in 2010-11 and 2011-12, we had additional funding to the amount of $79 million was available in 2010-11, and this year a further $170 million was available or is available for various patient-focused funding initiatives. The 79 and the 170 predominantly get spent on the non-ABF portion of patient-focused funding. So the procedural care program, the emergency department pay for performance, and in 2011-12, the community care program. Why did we feel the need to mess around with the funding of health hospitals and health authorities? And I think it really comes down to a growing recognition in British Columbia that elements of the block funding approach really have perverse incentives. The biggest one, I think, is that when you have block funding, and so you get a certain amount of money at the beginning of the year, and you're expected to care for your patients over the course of the year, and you don't expect to get any more money, well, each patient that you treat draws down that pool of money. So they are a cost. So there is a cost to providing care. There is no financial benefit to providing care to an additional patient. There is just a cost. And that's a really perverse thing to have a health system, have a health system do. There's also the slightly different but same sort of incentive, where if you can change, the quality of patients that you're, the acuity of the patients that you're treating, that there may be some incentive in say where there is targeted funding to actually treat lower cost patients rather than higher cost patients. The various forms of patient-focused funding that we have in British Columbia all change that incentive. In particular, the activity-based funding changes a big part of that incentive around. You cannot reduce your overall or improve your overall financial position by reducing your care for patients. So I've often said that if you wanted, for example, a system that generated wait lists, you couldn't get better than having a block funding system coupled with a physician compensation system, fee for service. You've got the incentive for the hospitals that are looking at the patient as a cost. You're looking at the doctors who have looking at the patients as a revenue source. The combination of the two means that there's going to be more patients who want the service than actually you have space provided for to provide the service. We also believe that the patient-focused funding or activity-based funding will provide some incentive for improved efficiency, and we saw that a little bit in Jason's talk. So hopefully what we're seeing in patient-focused funding is we're going to start taking advantage of those different incentives. Now, activity-based funding, the actual program that we're running, doesn't apply to all of the hospitals in British Columbia. We're applying it to the 23 largest hospitals with the philosophy that if we get 80% of what happens in British Columbia, we're making a big difference. So we do apply it to 23 of the largest hospitals, and we cover most of the inpatient and day procedure workload. There are some exceptions. Most of the provincial services are funded separately. Things like cardiac and renal services are funded separately. Maternity care is exempt because at the time that we established it, we were not including the largest maternity hospital in British Columbia, and so we just didn't want to provide any sort of weird incentives. So we just exempted maternity. We are continually thinking about whether or not we're going to be, expanding to different hospitals. We've got a couple of initiatives now looking at whether or not we're going to expand to a larger set of hospitals. But ABF, as it currently stands in BC, is as I've outlined. What we've done is we've established that we will pay to our health authorities, our regional health authorities, for all services all eligible services in eligible ABF hospitals. We're paying a set price per resource intensity weight, the RIW calculated by the Canadian Institute for Health Information. We're currently paying approximately $1,500 per inpatient RIW and $3,800 per day procedure RIW. So the advantage of that is that because the RIW is both procedure and patient specific, we think we've omitted most of the incentive for cream skimming. That is the incentive to treat the easier patients rather than the more complex patients. And because we're paying a higher price per day procedure, we believe, and I think there's some evidence that we are successful in moving some of our care, where appropriate, into day procedures rather than treating patients as inpatients. In 2010-11, it was the first year of operation. We spent $680 million, $680 million flowed through to the health authorities through activity-based funding. There is, Jason mentioned that there is a large tendency for these types of programs to rapidly increase spending. So in BC, we instituted a 3% growth cap, so that we set a baseline and said that, okay, we will only cover patients or RIWs up to a 3% growth. In British Columbia, in the first year, only one of our health authorities, the Fraser Health Authority, actually did that growth cap bind. It's still in place this year, and we expect we will continue. One of the issues that we had around activity-based funding is obviously it takes a bit of a time for people to learn about it, and so we did see an increase in volume, but certainly at the provincial level, certainly not not anything that we would be worried about. But we do expect that as people and the health authorities learn a little bit more about how to operate under the activity-based funding environment, that we might see larger increases of volume and larger shifts to larger incentive shifts around the types of patients that are being seen and the types of procedures that are being done. And also we expect to see some evidence of changes in efficiency. Our issues, I think for a fairly radical change in how we fund hospitals, I think we have a fairly limited set of issues that we've identified that are sort of worrying us. Certainly, Jason mentioned the lack of good costing. So British Columbia only has a couple of case costing hospitals, and so we don't have the best ideas on the costs, the actual costs of providing care. Even the RIW system is, it appears to be very good. We're using it. It in itself has some issues for a place, for British Columbia. Primarily, our biggest issue, I think, probably is the fact that because we only have a couple of case costing hospitals, the RIW doesn't really include, the calculation of the RIW doesn't really include BC data. The formula for calculating the RIW isn't estimated based on BC data. Coding delays. So when we started this, we had an up to a 4 or 5 month delay between discharge and when we would receive the extract from CHI. That has improved, and I think for most of our hospitals, I think all but one were under 2 months. So we're making, I think, good progress on coding delays, but it's still an issue, and it's especially an issue around the end of the fiscal year, where we have to have all of our finances up and done within 30 days, I think it is, of the end of the fiscal year. But at that point, we still haven't received the data for the RAWs. So there's some projection going on. The possibility of gaming is an issue that we're concerned with. We're working with CHI and with other agencies to try and look at detecting upcoding, for example, changing behavior, trying to basically game the system. We are worried a little bit about the growth cap, because once the growth cap is hit, it does reduce any of the incentive value of the activity-based funding, and we're a little bit worried that as we expect to see the health authorities get more responsive to activity-based funding, that might bind a little bit more. The need for cultural change, I think that's something that really has to be, it's something that I think is one of the most important issues. We really are changing how hospitals are funded, and we're changing the incentives. But as of right now, we still, for the most part, most of our system has been built up or grown up underneath block funding and isn't used to looking for the opportunities that an incentive system might drive. And so I think it is happening, and it's happening faster in some areas than others. But what we're seeing basically is that some areas are really much more able to respond to activity-based funding and the larger patient-focused funding initiative than others. Okay, so I think that's probably our experience in British Columbia around activity-based funding, and I'd like to turn it over to the moderators, and I'm here for questions.
Thank you both very much, Jason and Ian. Those were excellent and very clear presentations. I am happy to now open the floor to the audience. There are two ways that you can pose your questions today. Both English and French participants are invited to submit their questions electronically using the questions box located on the bottom left of your screen. And for English participants that are not connected via computer, you can ask your question verbally by pressing *1 on your touch-tone telephone. When asking a question, we ask that you please identify to whom the question is addressed, and please try to ask only one question at a time. Operator, at this time, are there any questions on the phone lines?
There are no questions on the phone line at the time. Please continue.
Okay. Well, we have a question that's come in from Alison Paprika in Ontario, asking, could you expand on which Nordic countries use a mix of ABF and global funding? I am particularly interested in about what are the common areas for ABF in instances where some of the budget is still global. So I hope that question's clear. I apologize. Jason, I think that's probably directed to you. You mentioned the Nordic countries.
Yeah, I'd be happy to field that question. It's a really great question because a number of the Nordic countries have experimented with or are currently experimenting with a mix of global budgets and activity-based funding. Currently, that cohort of countries includes Norway, Sweden, Finland, and Denmark, whereby they have a mix of a block funding, and that varies by proportion by country. I believe right now in Denmark it is a 60-40 split, so that would be that 40% of a hospital's budget are provided with global budget and 60% is based on activity. Other countries have varied that percentage. So, for example, in Norway, when they first implemented activity-based funding, they aimed to achieve I believe it was a 70% on activity and 30% on the global budget. They set a schedule whereby they were increasing the proportion of the global budget that was based on activity by 10% increments, so 0, 10, 20, 30, 40, 50 each year, whereby the hospitals could adjust over time to the proportion of activity that was based on activity-based funding. Other countries have not necessarily followed that and have moved to almost a prospective funding, so that is concurrently funding activity based on the episode type. And an example of that is Germany, where it would be a prospective system whereby it's all based on activity. However, the Nordic countries, where the hospital systems are most like our own, are varying degrees of mix of fixed and global and variable activity-based components.
Okay, thank you. I have a question from Kelly Stevenson with the CMA asking, does CHI data for resource intensity weights calculation use the DRG or the diagnostic related group information?
Okay, well, I'll leave that for Jason.
Yeah, I'll be happy to tackle that one. Currently, CIHI maintains a system analogous to diagnosis-related groups. Currently, the name of that system is called Case Mix Groups Plus, and it is a system whereby the discharge data or the abstracted data is summarized in ICD-10 CA diagnosis codes and CCI intervention codes. The basis of that is then used to, in a deterministic algorithm, assign patients into one of the CMG plus groups. And those are very similar to what DRG groups are. However, the CMG system that CIHI runs does have distinct differences from the DRG-based system used in other countries. Now, this is important to note that many countries, such as the United States and Germany and France and Norway and Sweden, Finland and Denmark, and all of the countries that have proceeded with activity-based funding, have developed variants of these systems, and they are called case mix systems. So Canada has followed these other systems, country systems in development, and developed its own.
Okay, thank you. I think we'll direct this question to Ian. It comes from, I think, Paulos Tekel, if I'm getting it correct, with the BC Cancer Agency. And Paulos says, nice talk, thanks. Studies in other countries on ABF or performance-based reimbursement, PBR, indicate that ABF may lead to increased efficiency, but it may have negative effects on the quality of care. And wondering, Ian, what does your experience in BC say about this? Do you try to compare within BC those who use ABF or PBR with those who do not, in terms of efficiency, quality of care, access, and so on? So the question actually, he says, is for both speakers, but maybe we'll turn it to you first, Ian, because you haven't had a chance to answer a question yet.
Sure. So, we're monitoring a whole bunch of things around the implementation of patient-focused funding. As my understanding of the research, and I think it was confirmed by Jason's presentation, is that actually the mix or the evidence around the impacts on quality is pretty mixed. We do monitor quality to the extent that we can, given that we are the ministry and not the hospital. But we do monitor quality. We're not seeing much change. I didn't mention that one of the things that we did sort of coinciding with the introduction of activity-based funding is that the ministry and the HSPO have funded the National Surgical Quality Improvement Program in a number of hospitals, and I believe all of the ABF hospitals actually are participating in that program now, as sort of our attempt to get at the quality question. It's certainly something that we're continuing to grapple with. It's not an easy sort of solution or an easy thing to do by any means. So I will say, getting back to whether we're monitoring it to the extent that we can. We're monitoring the efficiencies to the extent that we can, and we continue to develop those monitoring frameworks.
Did you want to speak to that as well, Jason?
I would just reiterate what Ian said, and which I mentioned in my presentation, in that the evidence with regard to the association between the implementation of activity-based funding and clinical care quality is very ambiguous. And in fact, there's certainly no definitive links between poorer quality and the implementation of activity-based funding. Okay.
In some ways a related question from Kevin Holder, who I'm guessing from his email address is in Kenora. In BC, are you finding that any of the 23 hospitals are now in a worse financial position than they would have been otherwise if global budgets were the only funding mechanism? And if not, are you seeing a negative change in the service volume, wait times, patient satisfaction, and so on?
Well, so in British Columbia, we have a we have a system where we don't. Although I sometimes talk about funding hospitals, we don't really fund hospitals. We fund health authorities, and the health authorities then distribute the funding. So, although the payment is based on activities in hospital, the payment goes to the health authority, and then the health authority then funds the hospitals. Now, at the health authority level, our first year of operation, we made a commitment that we were not going to have any health authorities suffer as a result of their participation in the activity-based funding. So we had sort of a commitment to keep them whole in terms of communicated funding. In general, we're not seeing, I think we had every health authority actually increased volume. Now, you can't in the ABF hospitals, but now you can't actually say that that's. Sorry, lost track of what I was going to say. So that's not necessarily indicative that in the absence of ABF they wouldn't have done better. But my belief is that at this moment no health authorities are suffering under ABF. Now it is possible that at some point, if we take it to its logical conclusion, that there will be some potential reallocation from one health authority to another. But again, at the hospital level, it's a much more difficult thing to say because of the fact that the ministry and the HSPO is funding health authorities rather than hospitals.
Okay, great. We have a question in French from one of our French listeners, Allard Guilain. Guylaine Allard from Aquest in Quebec. I'm going to read the question in English, but of course it's also available to people in French. So really wondering, how does this work in terms of remuneration for emergency services?
Okay, I'm assuming that's directed at me, and it's around the EDP for P program that we have. And basically what happens is that hospitals or health authorities are funded a particular dollar amount per patient that transits through the emergency department within set times. That depends on the acuity of the patient. So we have different target transit times depending on the CTAF level, and then depending on whether or not the patient gets admitted. And then after that, it's just a strict dollar value per patient that goes through within those times.
Okay, thank you. I also have a question here from Christine Lee. I'm not sure where her question is, where Christine is located, but she's wondering two things. First, what is the difference between case costing and resource intensity weights? And the second question, how did you estimate the 3% growth cap? So I'm going to ask Jason to answer that first question in terms of what's the difference between case costing and resource intensity weights, and then we'll go on to Ian about the 3% growth cap estimation.
Sure. I'd be happy to tackle the first part of this question. Case costing is the process of allocating hospitals' products to patients in order to derive their episode-based cost. So in other words, it is the process that's followed so that we can derive accurate estimates of how much a hospitalization cost. So it's more of a process of attributing hospitals products such as diagnostic imaging, laboratory, nursing intensity to the patient so we know how much of the resources they consume during their hospitalization. A resource intensity weight, commonly known as an RAW, is a normative or normalized value of how much patients cost. Its basis is the case costing data, but it's divided by the average of all patients. So, for example, an RAW value of 2 means that it's twice as expensive as the average patient in your province or in your jurisdiction. So an RAW value is a value. The case costing is the process to assign cost to patients.
Okay, and the second part, Ian, do you want to say how you estimated that 3% cap?
Yeah, well, we looked at historical volumes and historical growth in RIWs, and we basically made sure that we had historical growth covered plus, a couple or a percent or so. So, I mean, it was a little bit of the back of the envelope. It was, just did what we thought, the combination of historical growth and then what we thought was a reasonable amount of money to allocate to the system to handle growth.
Okay, thank you. Ian, I'm going to ask you the next one. It comes as well. This one comes from Pamela Foster with the Nurses Union. She's asking you, Ian, what new monitoring systems were put in place or penalties to prevent cherry-picking, misclassification, and to ensure improved quality? She's also asking, have you seen any documentation of burden on staff from moving to this approach?
Okay, so what new systems were put in place? Well, one of the things that I think we in Canada really have an advantage here is that the RIW system, when you pay by RIW, it really discourages cherry picking because the RIW depends not just on the actual procedure or, the treatment to the patient, but it also depends on comorbidities and, the overall complexity of the patient. So that, somebody who is a more complex patient maybe has, several comorbidities, will actually have a higher RIW than somebody who is having the same sort of care, but is a less risky patient or has fewer comorbidities. So I think the fact that we have the RIW system that incorporates that really discourages cherry picking. In terms of have we heard anything about increased burden on staff? Anecdotally, I have heard via the Nurses Union that there is a potential increase in the burden on staff, but we haven't heard anything and haven't seen anything in the data to indicate that that's true. It's interesting that I think I haven't seen any indication other than some statements by the Nurses Union.
Okay, thank you. This question comes from Jane Zhu, and it's for Jason. She says that some countries in Europe are not as large as Canada, for example, Denmark. So the fact that they are not as large, it may be easier for them to control hospital expenditures. So thinking now as a large country, which consists of different provinces, different cultures, and immigrants, how can Canada learn from those small European countries? To what extent?
Well, I think a lot of the things that we can learn have to do with the processes that have been used to implement hospital funding reform, such as the way that they led graduated implementation, some of the unintended consequences, and some of the observed effects. I think some of the unique challenges that Canada faces, not seen in some of the other jurisdictions that I've mentioned, have to do with the remoteness of some communities and the geographic density of our population in northern climes. There are higher costs. They are difficult to centralize services, provide equivalent or equitable access to health care without very high costs. And I think these are challenges that Canada is still grappling with in its infant stage of investigating the impacts of activity-based funding. I currently think that the evidence in this is certainly sparse, and I think it's starting to advance with provinces such as Ontario and Alberta and British Columbia taking small steps. So as Ian's discussed, they have taken 23 hospitals and have implemented activity-based funding. That is an implicit recognition that smaller hospitals certainly have different cost structures, different expectations regarding the way that they can change practices that serve their community. So I think that there's still a lot to learn here.
Okay, thanks. There's a question from Keith Gordon in Ontario. Are hospital physicians paid fee-for-service while the hospital is funded by ABF in BC? Maybe, Ian, you want to speak to that?
Yeah, and the answer is for the most part. We do have a large number of physicians in the hospitals who are paid on contract, but there is a significant number of them that are paid on fee for service, even though we have the activity-based funding. So in the extra funding in 2010, 11, and 11, 12, there was an amount of that funding set aside to cover increased fee-for-service payments as a result of the whole patient-focused funding initiative, ABF, and the procedural care program.
Okay. A question for Ian from James Chan at Northern Health. Is BC collecting data in an attempt to develop a method to quantify the cost of procedures in a better and more local way so that we can improve estimates of return on investment for quality improvement and other initiatives designed to impact efficiency?
I would love to, but the answer is, that's basically what we're talking about is case costing, and I would love to be able to say that BC is considering case costing, but the fact is that new information systems are very expensive, and at this point, we're just not able to do that.
Okay, and Ron Jansen from Manitoba is asking a question. I'm not sure if this maybe is directed towards Jason. It seems to me that activity-based funding has an inherent bias towards rewarding facilities and regions with relatively strong capacity to service volumes. What happens to regions and facilities that currently have capacity, for example, beds and other resources that are below national or provincial peers?
I think that's a wonderful question for which I don't think that I have an adequate answer. Certainly those hospitals that are able to meet the demands with the capacity are certainly in a position to be better able to leverage that in an activity-based funding environment. Given that the current system makes it very difficult to change bed types or to change capacity in hospitals to be able to take advantage of the financial signals of activity-based funding, certainly it would take many years to manifest those changes and be able to leverage that. So I think right now that's about the best I can do to try to angle in at that response.
Okay, I've got one more from Manitoba that I'm going to follow up with, and I don't know if I'm pronouncing the name correctly. It's Jide Balola, I believe. And this question is for Ian. Did the new funding system result in lower overall expenditure than the global funding system? And if so, how much was saved?
The answer is no. It didn't. That wasn't necessarily the objective. The objective is certainly to improve efficiency and to improve access, but lower overall spending was not an objective, and as a matter of fact, the first year there was the commitment to the health authorities that we would keep them whole, and so that there explicitly would not be a lower, that health authorities would not get lower amounts of money. So no, that wasn't, it's not an objective to save money, it's an objective to improve efficiency and to improve access.
And I would just like to also add to Ian's comments along that lines is most health systems that have moved hospital funding in this direction have also seen increases in expenditures, just as Ian's describing. In fact, most of the objectives are to improve access. So that is improving the wait times, improving or increasing the volume of care to get there. So most systems that implement this kind of change are not necessarily looking for cost savings. In fact, the exact opposite is usually true.
Okay. Judith Grossman from Alberta has a question, and she's posing it to either of you. I wonder if either Jason or Ian could elaborate on what seems to be an implicit underpinning of this approach to funding. That is, the collection of detailed and at times ongoing or repeated collection of detailed data by staff. Have any studies been done on the costs of collecting this data in terms of how labor-intensive it is for healthcare staff and whether this affects the time they can spend with patients?
So maybe I'll start. I think it's important to understand that the ABF system as built in British Columbia doesn't require any new data other than things that were already being collected. So we use the discharge abstract database from CHI. So that is already data that is being collected, and so there's no additional cost. We're using the RIW system that CHI had already developed, so there's no additional cost to that. Now, if and when we move on and start paying, if we were to say pay for quality, and to the extent that those metrics are not, or that data is not being collected or submitted to the ministry, that would be an increased cost. Now, at the health authority level, in responding to the incentives in activity-based funding, there may be an effort to get a better handle on say costs of individual procedures, even if they don't go to full, we don't go to full provincial case costing. There is an incentive to get a better understanding of what it costs to treat a particular type of patient or types of patients. That may be a cost. I think, frankly, that's something that we should already know. And I think the fact that we don't already know that sort of information is a failing of the block funding system. It's not a problem with the idea of activity-based funding.
I suppose a little bit of additional information that I would add to that is BC is able to leverage the data collection efforts that are ongoing in the case costing hospitals, which are predominantly Ontario-based Alberta and a couple of hospitals in British Columbia. Because without the basis or the case costing data that's collected in these other hospitals, CIHI would not be able to produce both the CMGs and update the CMGs, but also the RIWs, or the relative value units that Ian is able to reimburse hospitals with. There are certainly costs associated with collecting the case costing data. So, for example, the nursing workload statistics that nurses would be collecting, making sure that the costs or all the information systems are integrated. There are costs with that, no doubt. I haven't seen estimates with regard to how that cost is sort of manifest in terms of the hospital or in the health system itself, but there are costs there.
Okay, here's a question from David Lawson at Fraser Health. David's asking, given your experience to date, should there be a growth cap? You mentioned that some health authorities, including his own, Fraser Health, have exceeded the cap. How did European countries deal with cap issues?
I guess I'll take a stab at this. Most countries have implemented caps. I think that with the implementation of an activity-based funding scheme, there are certainly these incentives for hospitals to increase volume. However, certainly keeping in mind the issues of sustainability of the healthcare system, no government wants to be in a position where there are runaway costs in the hospital sector. That's no one's intention here. So generally what they do, especially during the transition time when it's uncertain with regards to the outcome of the changes in volumes and prices, how that might manifest. So what they do is they do often put in either what they call a hard cap or a semi-permeable cap. Now, in a hard cap, once you reach that growth, you're not remunerated more. In a semi-permeable cap, you'll reach your volumes in terms of your objectives, and after that point, your remuneration rate would certainly decline to some fraction of the original to discourage increased or runaway volume increases.
Yeah, and I'll just add that, in the first year of operation in British Columbia, we had a hard cap, and we had a hard cap on every health authority. So the cap applied individually to each health authority. But as I think in my presentation, at the provincial level, we didn't hit the 3% growth for the included hospitals. So in the current fiscal year, the cap has been changed so that it's a global cap, and if a health authority reaches the 3%, but the province itself is not close to that, there will be some possibility of reallocating the call it the cap room to health authorities that are able to that say if one health authority exceeds the cap and another couple don't. Now we don't know whether that'll bind in the end or not, because if everybody hits 3%, then there's no way to sort of reallocate.
Okay, and we're really running out of time, and there's so many great questions here, so we'll ask that you keep your answers short, if you could, just to try and capture as many as we can. This is from Suzanne Paré at Health Canada. She's asking, with the focus being more on value for money or sometimes pure cost containment, and the lack of evidence supporting increased quality with ABF, how do you think this approach is going to be received in Canada going forward?
So, I think there's nothing that there's nothing in activity-based funding that inhibits the idea of increased quality or value for money. I think activity-based funding and all types of funding mechanisms are one method that we can use to fund the system, and you can use it to achieve specific aims. That doesn't mean that the rest, that other things can't also be done at the same time. So I think it's important that this is not done in isolation. It's looked in the view with the lens of being part of an overall strategy around the system.
Okay, and I'm going to try and pull a couple here together that have to do with funding for rehab. Maureen Huntley has asked, has BC rolled out ABF to rehab and continuing care hospitals? I've got another one, if I can catch it. Oh, it's higher up. I'm again asking about, this is from Carissa Levy for Jason, and she's from the GTA Rehab Network. Can you please comment on episode-based funding and how this compares to ABF? So a couple of rehab, continuing care, and different funding model questions.
Okay, well, I will answer very quickly.
Our last question.
Yeah, I'll answer very quickly. The answer is ABF in British Columbia applies only to acute care, so it's not rehab.
Okay, and I guess I'll try and tackle the other issue a little bit around episode-based funding in the rehab sector or generally in the post-acute care sector relative to ABF. Now, currently, a lot of the provinces are exploring activity-based funding predominantly, and in BC's experience bears this out, in the acute care setting. However, that's not to say that tools and instruments analogous to episode descriptors and resource intensity weights do not exist, because they do in the other sectors. So, for example, I know that Ontario has the NRS, which is the National Rehabilitation Reporting System, which is based on the FIM, Functional Independence Measure, tool at admission and discharge, and they, like the CMG, are used to assign patients into distinct and unique groups, and there are cost weights associated with those. Now, it's my understanding to date that the Ontario Ministry of Health has not proceeded on the basis of funding episode-based care in the rehabilitative setting, but the tools are there and have been in existence for a number of years now. In other settings, such as complex continuing care and facility-based long-term care, is a little bit of a different perspective whereby they're not episode-based. They are actually based on the characteristics of the patient, and payment is based on a per-day basis. So there's no incentive in other settings to improve or decrease the length of stay. Moreover, it's more to be able to fairly compensate the facilities for the clinical characteristics and the needs, rehabilitative services needed by the patients there. So for each different setting, there are different tools, and they've been applied to different settings in different countries at different times. So, for example, in the United States, an episode-based payment system for inpatient rehabilitation has been used for approximately 10 years. And much like the acute care setting, this is associated with no observed decrease in clinical quality or outcomes. It has shortened length of stays and improved access.
Okay, and regrettably, we're going to have to end the questions there. We're absolutely thrilled to have had so many excellent questions coming in, and unfortunately, we have not been able to get to all of them during the call. But I want to assure you that if your question has not been answered, we will be sure to get these to our speakers following our call, and they will get back to you. So, Jason and Ian, thank you so much. It was just an excellent session. And thank you to our participants for their excellent questions. We hope you'll be able to join us for our future sessions. There's more information on the full CHSRF on-call lineup that can be found at www.chsrf.ca/on-call. We also encourage you to sign up for our electronic newsletter at CHSRF to stay up to date on CHSRF activities, and we would greatly appreciate your participation in a very brief survey about today's CHSRF on call. Links to the survey will be sent via email in the next 24 hours. So, again, thank you. A sincere thank you to both of our speakers, Jason and Ian, and, of course, our audience for your participation today. And that concludes today's CHSRF on call. I'm Jillian Mulvale.
Thank you. Ladies and gentlemen, this does conclude your conference call for today. We thank you for your participation. You may now disconnect your lines and have a great day.